Hi, team. So you've probably spent the last 2 to 3 weeks going through assumption of cares. Very long, very tedious assumptions where you're filling out and doing research on social history, on surgical history. And so these are taking you quite some time. You've gone through and not really felt a part of the clinical team at this point, but you have gotten used to the facility, met some nurse managers, hopefully worked with the DON, and been able to be a part of learning each individual patient. So from here on out, we're prepping you for clinical meeting, which you will start to go to tomorrow. So this is just a review of what kind of things you're going to be doing once you hit clinical meeting. So our objectives today are going to be to learn how to navigate point-click care for those reports and to figure out who or what patients are of priority to see in that day. So as soon as you start collaborating and getting this information, you're going to start writing names down on a piece of paper. And by the time the morning meeting is completed, you may have 20 or 30 patients that can be seen. That doesn't mean that you're going to see them all. We're going to prioritize which ones are the most important. And then whatever is residual, you can see tomorrow as you're adding to that list again. So first thing that you're going to do in the morning is you're going to review the ADT, the admits, the discharges, the transfers. So reviewing admits and readmits. I usually made my list the night before of anyone that was a new admit, or, and that was late at night, not late, late at night. So like 9 o'clock at night, or I would do it at 6 o'clock in the morning and get my list. So I knew who was a new admit or who returned from the hospital. I also had a running list as soon as I got home if I got calls for patients. So if they needed a new prescription for pain medication, I would write it, but then I would see them the next day, find out about their pain, their quantity, their quality of pain, anyone that had nausea, and I started them on Zofran. Those are my first priorities of the day. When I hit that building, those are the ones that I'm going to see. And I know that I've already given away a little bit of this, but I print out my face sheets for every new admit or readmit. On it, I've got a little bit of my social history, I've got my diagnoses, I've got my room number, and that's the place that I head first thing in the morning. You are going to talk to your DON and find out what time clinical meeting is, not stand-up, clinical meeting. That's where you're going to be able to gather a lot of your information. So where I would say the majority of clinical meetings are the same in most facilities, and I've worked in many facilities as a DON and a nurse practitioner, they're different in every way, but they still have the same general information that they're reviewing. So if your clinical meeting looks a little bit different than what I'm showing you, this is still the information that you'd want to gather, and I walk you through how to gather that. So if your clinical meeting starts at 8:30, then I would go and do these super fast. If your clinical meeting starts at 10:30, which some do, if you can believe that, they're starting their day, and we're halfway done with our day at that point, then that's a time for you to find out and go through all of these things to get that information. We're going to look at high-risk patients, so that includes weight losses, and we're going to pull that report every week. New antibiotics, I pull every single day. I want to know if there's any new antibiotics, and I want to be reminded of those that are on the high-risk antibiotic list. So any ertapenams, imipenems, any IV antibiotics, any Dapto that are on for 6 weeks, Vanco. So I want to see those on a daily basis, but you can run the report every day or every other day, and that would be fine. I want to look at new psychotropics, and I usually review these once a week, a couple of days after the psych nurse practitioner sees the patient and makes changes. Falls, I'm going to look at every single day. Every single day. These are going to be the ones that are starred on your little list, and those are going to be your priority patients of the day, making sure that the falls that were over the last 24, 48 hours, if it's the weekend, those are addressed immediately. Any kind of risk management, which includes falls, but also includes new wounds, any resident to resident altercation. Those are priority patients for me as well. And then my wound list. And I wish I could figure out how to get a list from Point Click Care. Some things like Santyl or gentamicin, packing, you could pull by drug name and you might be able to see that. Other things that are clean, dry dressings or alginate would not be under medications. So in order to find them, you'd really have to look at every single order in the building. So getting that wound list either from the DON, my thought is to get it from the wound doctor before they leave, or have them email it to you, or you can get it from the wound nurse. Any place you can get it is important enough to get it, but the wounds you're not able to get from Point Click Care. So to access Point Click Care, you could be accessing it through Citrix. Some facilities access through Citrix still at this point, but most of them are either transitioning off of Citrix, where you would just go through your local server. But if you're still using Citrix, you would utilize it through there. So first daily tasks to be reviewed are the changes that occurred in the facility. So again, if your morning clinicals don't start till 10:30, that doesn't mean you don't have patients to see. I'm going to show you which patients to see. So as you're seeing these patients and you're going from unit to unit, and my goal is for you to just see one unit at a time, then the next unit, then the next unit. I don't want you going back and forth to unit 1, unit 3, unit 2, unit 4. I want it to be pretty consistent around the board, but you're going to just see if there's anything going on. So speaking with the nurses daily, so speaking with them at 7 a.m. is probably not the best idea. The rationale behind that is they're getting report and they have no clue what's going on. And so some of the report may be that the patient's fine, nothing, haven't heard anything. And as the day goes on, they might have more information, as well as when they're done with report, they may have more information. So speak with the nurses daily, but just know that if you do it early, they may not have that information yet. You're going to review ADT, your admits, discharges, and transfers. And I'm going to explain each of these sections, but these are the areas that I want you to hit, and I've walked you through how to do that. So for example, admits, discharges, and transfers, you're going to go under the clinical tab, under the care management tab, and under the dashboard. And usually it's about halfway down, although everyone's desktop may look different. So it may not be halfway down, but you're going to be under the dashboard and you're going to specifically be looking for admits, discharges, and transfers. You're going to review the labs. To find the labs, you're going to go same place, clinical. You're going to go back to the care management, and then you're going to select lab results instead of your dashboard. So same area, only you're picking the dashboard here and you're picking lab results here. Your risk management is super important to address. You're going to go to your clinical. Again, you go to the care management, and it's usually one or two areas below the labs. You're going to find risk management. Once you find risk management and click it, you're going to click active. It actually comes up with a dashboard, and you're going to go to the active section of that. And you'll be able to see new falls, new skin issues, any new behaviors, anything specifically that's going on. you're going to review your antibiotics. So this is specifically different than some states, but for your state, we're going to find them under clinical, again, care management and dashboard. And at the bottom, usually, not always, but usually, you'll find the antibiotics section. You'll also find the psychotropic section. So if you've noticed any theme here, most of what you're going to find is going to be on the dashboard. You've got your admits and discharges, you've got your psychotropics and your antibiotics. So most of the things are going to be under the dashboard, but all of the things are going to be under your clinical tab and your care management. Your weight losses, you're actually just going to print a report for. So you would actually click into the reports, click into weights and vital exception report. That's the name of the report. You're going to uncheck all of those vital signs. You don't want all of them. You're only looking for weights. You're going to select the weight, select the current month, and it will show you up to 1 month, 90 days, and then 6 months on that. So let's walk our way through, since I've explained it in a kind of written way. This is kind of a visual way. So if you're able to navigate with directions, that's a good page to go to. But if you need to reminding, I've got reminders here. So again, our first task of the day, whether you do it the night before or early on, is to get to those new admits and readmits. So you're going to go to the review ADT and you're going to date range them to 3 to 5 days. Again, this is a me thing. I love to print my face sheets for my new admits. It gives me my diagnosis. It gives me my demographics. A lot of social history is on there. And so that's where I want to be. So I've given you an example. If you look at the section before the slide, it will tell you to go to clinical, care management, and dashboard. Here we go. So here is your clinical tab, and then it's going to give you your care management, and you drop down and you go to dashboard. And then your ADT is about halfway down, but it could be at the top or the bottom of your screen. So if you can't find it halfway down, make sure you go through your entire dashboard. So we're looking for admits, discharges, and transfers. It is going to provide you with a list of patients that need to be seen, hopefully before clinical meeting. If you take a 4-day weekend or a 5-day weekend, or if you have a 4-day weekend with a holiday, you can date range this. So it goes all the way up from 1 day to 7 days. And then from 7, it goes to 14, 21, and 28. So I do rounds once a week. So I date range it for 14 days, just in case I missed that one last day or the day that I was in there and there were admits that came after that. But you can just date range it for the last 3 days every single day, just to make sure you're not missing anything. It will provide you with a list of patients to see. And then like if you've got a holiday or if you took a day off because you were sick, I changed the date, not a big issue. So admits that come in over the weekend need to be reviewed meticulously. That's not to say that admits that come in during the week don't need to be reviewed meticulously either. They all do. But remember, on the weekends, you have less management in the facility, probably not too many unit managers, ADONs, DONs. And so potentially a nurse who has 20, 25, 30 patients is doing this admit. So their main function is to get the medications in, whether they get the right diagnosis in, whether they get the all of the other follow-up appointments. Their main goal is to get the medications in. So when you're looking at that, make sure that you've got the correct everything. So antibiotics, sometimes they put them in, but they forget their stop date, or the hospital doesn't give you a stop date. If they're a readmit, make sure that all of their previous medications that were on their MAR last time are now on their MAR this time, unless they stopped. So 2 examples. One, they had Lasix 40 twice a day. They went into the hospital with acute kidney injury. They come back on Lasix 20. Do you reinstate all of those different Lasix? No, of course not. But you have a patient that goes in, they get a UTI, they come out, they're on 3 medications. Make sure you put that vitamin B12 back in, that vitamin D3, that Prostat or that MedPass, or if it doesn't have a diet on there and they were dysphagia and they only went for a UTI, make sure you put that diet in there. Any referrals that they had, maybe they were an original hip fracture, they were supposed to go to ortho. All those orders are discontinued when the patient discharges out of there. So make sure anything that was on your old MAR and TAR get addressed. Now you're going to do a skin sweep anyway. Every primary care nurse practitioner, they're going to look at all areas of the body, especially the heels, the buttocks, the back. We're looking at important areas. But if there was a wound that was noted before, you definitely want to put that back in place. So if it's looking the same, you can use the same orders, or if there are new orders, make sure you do that. Make sure you do the referral to the wound doctor and let him or her know that they are back from the hospital. Make sure all medications in the computer have the correct dose. So I think if you look for Remeron in the computer, it'll give you a 15, a 30, and a 45 dose. But if you look at mirtazapine, it will give you a 7.5, a 15 dose. So if they've put in Remeron and there's no 7.5, and they don't know how to put in a 7.5, they might just put in the Remeron, and then under dose, they might put 7.5. That order needs to be adjusted. The pharmacy needs to know what medication to administer, not 7.5 of something. Is it a 7.5 tablet, or is it a 30 cut in quarters, or is it a 15 cut in half? So make sure that the medications have the correct dose on them. Same thing with a vitamin B12. Don't just click vitamin B12. You want to click vitamin B12 5,000, 2,000, 1,000, whatever it is. Sometimes the nurses don't get that. So make sure we've got the correct dose. Remember, when you say that you've done a medication reconciliation on the patient, that includes making sure you've got the dose, the route, the diagnosis. Everything needs to be meticulous. That's not always the case on the weekend. So please double check that and make sure that that's being addressed. Any medications that require labs. So if you've got a patient that's readmitting, they've been gone for 2 days, and you've already got an A1C and they've already got a TSH from a month ago and you're doing them every 3 months, that's not necessary. But if you've got a brand new patient that's a diabetic that has thyroid issues that needs a CBC, CMP, TSH, A1C, if they've got vitamin B12 on their medication list, get a B12 level. If they've got vitamin D3, get a vitamin D25-hydroxy level. So make sure you're doing the appropriate labs. Don't just blanket CBC, CMP, and then be done. And remember, CMPs are always better. It gives you your kidney function, it gives you your electrolytes, it gives you your protein status, and it gives you your liver function. So make sure you're always ordering a CMP for that initial. It will show you on your ADT your discharges. So the assumption is that you should know who will be going home to the ALF, discharging out of there. Earlier on in the week, we talk about that during clinical meeting. So as soon as you find out a patient is going home, you're going to want to go in and do a face-to-face visit. The face-to-face visit is dated on Monday. You open up the note and you complete it all. When you come back on Thursday and you notice the patient's discharged, then you can go back into that computer, into the note that's dated on Monday, and click submit. The submit date is going to be Monday. That's the day you did the face-to-face. So knowing who discharged is important. Also knowing if they went to the hospital. Did you miss something? Did the patient get sick all of a sudden? Are they at high fall risk so that that patient needs to be addressed when they come back? That's the kind of stuff that you're looking for. And then payer changes. You'd think, why do I need to know about a payer change? Well, if the patient was Medicaid pending and you haven't been able to see them, they had no Medicare, they were just Medicaid pending, but now their Medicaid has gone through, you can see that patient and you can put them on an every month schedule to see that patient. So very important for the patient to be seen if that happens. Now, if you have a Medicare patient that went Medicaid and they've been Medicaid for 2 or 3 weeks, they've had a decline and therapy picks them back up and they go back to Medicare A, you would want to see them more frequently. Why? Because they're having a decline. Therapy is noticed a decline. What other declines are they having besides their mobility? So you would want to know all of the payer changes on that. Remember, we've talked about admission notes, and I should have given you a couple of examples on here and I didn't, and I apologize. But admission notes include the reason the patient was in the hospital, significant findings, what went on in the hospital, if they had surgery, if they were in there for an extended stay, and then now why are they here in the SNF? So that could be for physical, occupational therapy, for wound care, for IV hydration, IV antibiotics. So why are they in the SNF? There is that little section above the HPI that stays. It stays until you delete it. So if it's a new admit, go ahead and put a hospitalization record in and make sure that within 30 days that is deleted out, because the hospitalization report goes from note to note to note, whereas the HPI does not. So you definitely want to have some of that recall in there for why they were hospitalized. But after a note, now it becomes more of a cut and paste or a copy and paste, and it stays in there for a long time. And does that really affect the patient a month after, 2 months after, 3 months after? It does not need to be captured in the note. You're already seeing the patient. You already know why they were hospitalized. So get that out of there within 30 days. Do they have IV antibiotics, PEG tube, skilled therapy? Put that in under the hospitalization and then get rid of it after 30 days. If you know their discharge plans, go ahead and put that on there. If they're going home with a wife, if they're going home with a spouse, if they're going home with family, if they're going to the ALF, put that on there. And then in green, same as our PowerPoint for new hire orientation, if they're long-term care, write a brief statement on why the patient would not be able to go home. Some patients don't have a home. Some patients don't have family that can help them out. Some patients require too much care. Maybe they've had a stroke, and so they won't be able to have assistance at home. So if you know that, just document that. And you only have to document it on the first one, on the admission note, and then not again. Other things we said. So this is something that you could be working on as you're waiting for clinical meeting, or you can be working on during clinical meeting. But it is MANA nurse practitioner's responsibility to clear the labs out every single day. So if you've got a physician that is very particular and says he wants to clear out the labs and he has 10 patients, like there's maybe 1 or 2 facilities I'm thinking about, fine. But if each doctor says they want to address all of their labs, it is the protocol of MANA, who does support the facilities there, to clean out the labs. That means you're going to go into the labs, clinical, care management, and lab results. You are going to view results. Then you're going to click into the patient, find their results, review their results. If there are some things that need to be addressed, we need to address them. If there are some things that maybe you didn't order the lab and the doctor did, then and they're over your head, you can just text the doctor with a secure chat, either WhatsApp or something secure, and let them know that their results are in. Don't leave them under lab results. If they're the doctor's labs, the doctor knows what labs they've ordered. So this is a hard thing to deal with if you're a doctor and they're just wanting their labs reviewed, but the doctor comes in once a week. So we're going to review them. We're going to clear them. Anything that you don't know how to address, you're definitely going to share with the physician. But what we don't want, at the top of every lab, once you click reviewed, your name, your date, and the time gets logged on the top of that lab. So if the doctor doesn't come in except for every once a week, that lab doesn't get addressed, or maybe it was addressed, but their name, their date, and their time is now on the lab and it's a week late, and that indicates a delay of care. So then it's going to be an investigation on maybe the doctor did address it but didn't sign it off for a week. And so there's always that question, whether it's a survey or litigation issue, of why you didn't address that, why you didn't sign it off. And the doctor can say, I gave orders, but they didn't sign it off. So they didn't really view the entire lab. They might have reviewed one section of the lab. So it is very important that we do that on a daily basis. Monday morning, first thing, you clear out all of your labs. You're going to mark them as reviewed and then close, and it will fall into the patient's records. So this unreviewed laboratory should always be 0 as you're doing it first thing in the morning. And then a lot of labs that are drawn that morning come back later on that afternoon. Remember, we're on call until 7 p.m. So if those labs come back at 3, 4, 5, we should have a process in place where when you're done charting at the end of the day, you're looking for your labs. So not only first thing in the morning, but at the end of your day. Unmatched laboratories, what that means is somebody has spelled the patient's name wrong, or there's a wrong birth date on there. And so you're going to have to click into unmatched laboratory, and you're going to have to pick out whatever patient they're thinking of. And it might give you 3 or 4 choices on who you think that patient is. You click it. Once it goes from unmatched laboratory, it plops into the unreviewed laboratory. Then you can sign it off. Remember that all significant results need to be addressed. So that includes interventions and follow-up labs. You've got a low potassium. You're going to stop what you're doing right there. You're going to put potassium in place. You're going to put a follow-up potassium level. The patient's name goes on your list. They're a starred patient. This patient needs to be seen, depending on how low or maybe even how high the potassium is. You may need to get a stat EKG. If it's critical, then you have to make the decision with collaborating physician that you're going to transfer the patient out. But always, if you're transferring a patient out, collaborate with the physician and let them know. If it is a low vitamin B12, their name can go on your list. You put low B12. Even if it's within parameters. So parameters for a vitamin B12, it depends on what lab you're in, are like 250 to 800. If you've got a vitamin B12 that's 300, that's low. It might be normal, but it's normal low. 400, normal low. They might need either an increase in their vitamin B12 supplement or to start on one. From a mental health standpoint, from a mood standpoint, from a fatigue standpoint, you want a higher level of vitamin B12. But that's not an urgent patient that needs to be seen. Yes, you would want to see them. You would want to find out if they're having any symptoms of low vitamin B12. However, it's not urgent. and so it wouldn't be starred. Again, we're making a list of 20 to 30 patients and we pick our priorities. So our priority is definitely the higher low potassium, but the priority would not be a low vitamin B12 or a vitamin D3 level when we could see them potentially in the morning. So this is a big thing. As I see new nurse practitioners writing the HPIs, and even some of our older nurse practitioners, older meaning been with the company for a longer time, not age-wise. When you write an HPI, not only are you writing a great review from hospitalization, which a lot of you are, but then your HPI says patient sitting in the dining room. Okay, like where is the rest of the HPI? Like maybe they have dementia and they are sitting in the dining room. Maybe you're not going to get a lot of information out of there. Maybe you are going to define, do they look like they have any pain? Have you asked the CNAs, are they eating well? And so you could ask the CNAs, how's their appetite? And you can write staff reporting appetite well, eats well, participates in activities. You can ask the nurses, are they having any pain? Are you medicating them for pain? Are you addressing skin? You should be. You should just not say that they're sitting in the dining room. This is a whole evaluation, especially with your initial evaluation. So when you're doing your HPI, I want something more than sitting in the dining room. I want something more than patient has dementia and is nonverbal, because they're not the only one participating in their care. You've got family, you've got staff, you've got activities, you've got CNAs, nurses. All these people are participatory in this care. So I want you to make sure that you're addressing an HPI for what it is. It is not a novel. You don't need a paragraph for everything that's going on. But what you do need is to have information on what's going on with the patient. So any chief concern or interval change, I don't want your initial chief complaint to be follow-up. I don't want it to say monthly evaluation. There is a reason you're seeing this patient, a medically necessary reason. So if they have diabetes and we're evaluating their blood glucose, throw that in the HPI. Like we want to know not that the blood sugar was reviewed, but that the blood sugar log over the last 2 weeks, 3 weeks, 4 weeks have been reviewed, that their A1C has been reviewed, that labs have been ordered. That's what we're looking for in this HPI. Again, not a novel, but not that the patient is sitting in the chair. So I want a mix of that. So what is the chief concern? Why is the patient being seen today? It might be for chronic care management, but what's their chronic care? Is it hypertension, CHF, and dementia? Why are they being seen? Is the issue new, worsening, stable, or improving? Now, you're going to address that under your assessment and plan, but you can also address it under your HPI. I don't want duplicate. I don't want you to have to write that whatever is new here is new here. But again, if it's new, you're going to want to follow the old carts and get that information. And if they are requiring more assistance, you don't have to write worsening, but you could write staff report the patient requires more assistance. Staff reports patient is now clenching teeth and after 3 to 4 bites of meals and oral intake has decreased. Anything that is a symptom, you would want to use old carts. So onset, location, duration, character, alleviating factors. You can also use this for pain. Patient exhibits pain to wherever, lower back. Nursing reports that patient is medicated either routinely or as necessary. Then you can look in and see how many times they're getting pain medication per day. Patient is grimacing, has no grimacing, clenching of the fists. whether you're using the FLAX score because they're demented, or whether they're giving you a scale. It is great when you say patient complains of pain, 9 out of 10. Now I want the location. I want the quantifiable factors. And you can ask them, is the pain sharp? Is it stabbing? Is it radiating? Is it pins, needles, heaviness in the feet? Are we talking about neuropathy? So get that information. So I want a location. I want the quality of the pain and the quantity of pain. And if they're taking pain medication, how are they doing? So you've got a patient that's on routine pain medication and they are having no pain. You can ask them, what is the worst pain you've had over the last 7 days? And they will say, but pain is really controlled. When the pain medication is wearing off before your next dose, are you having any pain? Most likely they'll say yes. It's usually a 4 or 5, or they'll say it's a 7 before I get my next dose. So get that information in there. Their functional impact. So especially where we don't have all that information from the dementia patients, what are we talking about for ADLs, mobility, sleep, mood, appetite, or cognition? I ask every patient, how are you sleeping? How are you eating? How is your appetite? How is your mood? And how are they doing? So the patient that was transferring independently has fallen 3 times. Now they're needing assist. Write that in there. Any interventions that we're doing. So if they have, if they're at high fall risk, or if they are had recent falls, you're going to be wanting to address that. Okay, so I just wanted to finish this little section up here. If you've got any kind of treatments, medications, or therapies, so if the patient is getting skilled PT and OT, put that in your HPI. It's not going to go below, because our plan would never include PT OT unless it would have a medication associated with it. Pertinent negatives. So don't list on the review of systems a whole list of no, 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 no. If you're going to say no chest pain, palpitations, chest pressure, put that under either hypertension, CHF, whatever you're addressing. If they have GERD and they're having trouble and they're having nausea, then you can put nausea, no vomiting, diarrhea, or constipation. But do not list a whole series of negatives. Your negatives go behind whatever you're addressing. I hope that makes sense. And then if they've had any recent hospitalizations, falls, infections, medications, so the patient just completed antibiotics for whatever, and then your follow-up to that. No signs or symptoms of whatever they had, and no adverse effects related to antibiotics, and we'll get to that. But please make sure your HPI has some kind of information that is pertinent. So under your labs, clinical care management, lab results, you're going to go, did I already do that? I did. We'll skip that. Okay, so under risk, review the risk, the clinical care management, risk management, and active. So under clinical, under care management, and then you're going to go under risk management, and then you hit active. Remember, I told you you'd have to go under active because it automatically pulls up this summary. So the list may be from months or just weeks. It depends on how fast the administrator locks those out. But you're going to scroll to the bottom of the list to see any new incidents that you need to address. And so make sure you go back Friday, Saturday, and Sunday. You're going to sort by date. You're going to see all the new fall skins, behaviors, etc. That's stuff that you would want to document on. So again, Monday morning you come in, make sure that you haven't missed anything from Friday, Saturday, or Sunday. Those are the least documented on, and we want to make sure that we've hit that the best. Fall documentation. Falls are one of the highest litigation reasons, as well as weight loss and wounds. So we want to know what's gone on with a fall. Now, our fall documentation has increased and improved significantly. Two reasons why. There are snippets under the HPI, and it tells you exactly what to chart. And then there are snippets under the assessment and plan. And so use that one as well. So under your HPI, you're going to describe the fall, what happened, how the patient is doing. And then under your assessment and plan, what your plan is. What did you do, including medication review, vital sign review, any kind of labs you ordered, referral to therapy. And so those two things have made a huge difference in our documentation. So what is known about the fall, what the patient says, how they were found. Patient was found on the floor next to the bed with a head near the foot of the bed. Patient was found, appears he slid out of wheelchair going to the bathroom. Patient reports he stood up to get his telephone, which had fallen off of the nightstand, and fell to the floor. Whatever it is, what do we know about the fall? And then you're going to want to address three things. You're going to want to address skin. Do they get any skin tears? Do they get any bruises, any abrasions? Then you're going to want to address their range of motion. So that, do they have any pain? Is their range of motion within normal limits? Even with a hemiparesis or a paraplegia patient, you would want to address their range of motion. So if the range of motion is normal for them, you can put normal for a patient, within normal limits for patient. That's taking into account that they have hemiparesis, and that range of motion might not be great, or their contractures might not be great, but it's normal for this patient. And then cognition. If they're confused, I'm wanting confused at baseline, because if you have alert and oriented patient that's confused, they need to be transferred to the hospital for a CT scan. So we want to say, if we're doing a cognition and they are confused, that they're confused at baseline, or that they're confused, new confusion, unable to remember what happened during the fall. So did we have a seizure? Do we have something going on in the brain? That's important. And then under the assessment of plan, and of course this is under the snippets, you're collaborating with the IDT team. So make sure under your collaboration section that you're writing that you've collaborated with the IDT team about their fall. Antibiotics, you're going to go under clinical care management, and then under dashboard. Here's clinical care management under dashboard. And then you're going to go to the antibiotic medication and date range it, usually 7 days. You don't have to date range it past that, but the date range is 7 days for antibiotic medication. And it will show you, again, because it's on your dashboard, and your dashboard you'll spend a little bit of time on. It's going to show you everyone that's current with antibiotics. It doesn't show you what they just completed. If it's a resolved antibiotic, it will fall off this list. So all infections should be documented at the start of antibiotic therapy. So if the doctor comes in and puts them on antibiotics, the very next day, you would want to say patient started on antibiotics per MD related to whatever. So this is where we discuss the symptoms and the location of the infection, as well as any pertinent negatives. And I'll show you what that can look like in just a minute. All infections should be documented during antibiotic therapy. Rationale why is because how are they doing on the therapy? Are we getting some resolution of those symptoms? And then are we having any side effects of that? And then at the completion or the last day that they're on antibiotics, or 1 day later, are their symptoms resolved? Is there closure with this infection? Is there any side effects that are residual? So we're looking for local findings. We're looking for systemic findings. We're looking for findings that are atypical in older adults. And one thing that just comes to mind is urinary tract infections. They look different for older patients than they do for the younger population. And then complications to watch for. So this is not how I need you to document, but these are 3 examples that I came up with. So signs and symptoms of cellulitis, so local findings, systemic findings, and then complications to look for. So if you're going to say patient has cellulitis to right lower extremity, redness with poorly defined borders, swelling and edema noted, warmth to the affected touch, no tenderness. So here's your negatives: denies tenderness or pain to touch. You can write skin firm or not firm. Skin is not tight or firm, and there is no skin breakdown, blistering, or drainage noted. So maybe they are just red with cellulitis, but they don't have any of these. So use your pertinent positives and then follow that by negatives. Patient has no fever or chills, malaise or fatigue, lymphadenopathy, but you could write a patient with noted elevated white blood cell count of 13.5 with redness to bilateral or to right lower extremity with poorly defined borders. So utilize what you've got as positives that substantiate this infection. And then these would be your negatives. Now, you don't have to use all of them, but you can use a good chunk of them to really define your cellulitis. We will continue to watch or monitor for complications such as progression of erythema, signs of abscess or necrosis, and then if you want to write that, or sepsis if untreated. I've got one for an upper respiratory infection. Again, you don't have to use this, but what are your symptoms of an upper respiratory infection? So a lot of people say patient noted with upper respiratory infection and a cough. We'll start on Zithromax. Zithromax is a very popular medication for someone with an upper respiratory infection. And then how do you justify that they have an upper respiratory infection? So maybe they have a congestion or rhinorrhea, or they're sneezing, they've got a sore throat, they've got a cough, hoarseness, mild ear pain or pressure, or low-grade sinus tenderness. So use your positives first, then put your negatives. No increased confusion or lethargy. Maybe they do have a decreased oral intake or appetite. So one of your plans may be to provide soup for them for 3 days at lunch and dinner, or clear liquids or thin liquids, so that they're able to keep hydrated. Complications to watch for: you can write that we'll monitor for secondary bacterial infection, prolonged or worsening symptoms, high fever, chest pain, or shortness of breath. So use your positives and then your negatives. I got one more for you. I thought it might help. I got cellulitis twice on there. UTI, so local or urinary findings. So patient complains of dysuria and urinary frequency with urgency, denies any suprapubic discomfort or pressure, no hematuria noted, no foul or cloudy urine. Patient has incontinence. So we will obtain a urinalysis with a culture and sensitivity to rule out a urinary tract infection. So increased falls is an atypical finding that we find in older adults. Please do not do a urinalysis on every patient that has fallen. That is not the process here. Generalized weakness or functional decline. If all of a sudden, not gradually, but all of a sudden they can't get out of bed or they're not doing their new stuff, then of course we can look at that. But we don't want just to say that they fell, we're going to do a urinalysis, because a lot of patients, about 30%, have asymptomatic bacteremia. And so we don't want to medicate patients if they don't have any symptoms of an actual urinary tract infection. So there, we do a UA and they come back with 100,000. And so we start them on antibiotics when really it's either colonized or they have asymptomatic bacteremia and we don't want to medicate for them. So just watch that and make sure that you've got something other than a fall going on. Psychotropics. Blank. I hope I got it somewhere else. Antibiotics. You're going to go to clinical care management. Under your dashboard, you're going to go to clinical care management and then go back to your dashboard. I told you you would see that. I'm going to have to pause this for a second. Okay, so I think I fixed it. Okay, so psychotropics, we already did infections. Go to the psychotropic medication and date range it, usually about 7 days. You should be looking at this at least once a week. And so psychotropics. So the question is, why are we doing psychotropics and reviewing them 2 to 3 days after the psych nurse practitioner is changing medications? Like they're not going to be better at this point. Well, here's the deal. We're looking at them 2 to 3 days after starting, increasing, decreasing dosing. So find out when psych NP comes in, and then like let's say they come in on Monday, you're going to be following these guys on Thursday or Friday. So any antidepressant that is new or that is increased or decreased, you are looking for suicidal or homicidal ideations. Side effects are higher the first week of starting an antidepressant or including any other psychotropic medication. So you want to address that in your documentation. And you also want to address side effects. Now, there are many side effects for many different medications, but GI side effects seem to be one that pretty much hits most medications. But with SSRIs, side effects are usually GI, dry mouth, nausea, sometimes diarrhea, sometimes constipation. It depends. But you're looking for any kind of side effects from that. Their depression is not going to be better. So don't assume you're going to be writing this letter saying patient is doing great now, is now participating. If that's the truth, then go ahead and write that. Just don't assume that they're going to get better after the 3 days, and that's why we're documenting on them. We're documenting for the suicidal ideations, and we're documenting for the side effects. So let's say they're on Remeron. Remeron, we're looking for the improved appetite, and maybe within 3 days we should get that. If we're talking about trazodone, we should be feeling better or getting a little bit more sleep. So then let's go on to an anti-anxiety. So if you start an anti-anxiety medication or you increase it, they're restless, they've got chest pain, palpitations, just anxiety, panic attacks, you should feel better when you start an anti-anxiety, whether it's Buspar, Xanax, Ativan, clonazepam, Valium. There should be an improvement pretty fast. And it may take up to 2 weeks to get to optimal level. But if I give you a Xanax right now, you should be a little bit more mellow than you were half an hour ago or an hour ago. Same thing with the Ativan. You're going to get pretty instantaneous results from that. Now, that's what we're looking for, is if they're having decreased restlessness, decreased anxiety, decreased panic attacks. So again, we're not necessarily expecting them to get better, but we are expecting a little bit of improvement. On the other hand, if you're decreasing, especially Xanax, you're likely to have rebound effects. If you're doing a gradual dose reduction on something like Ativan, we're watching to see if their anxiety is getting worse or if they're having more restlessness. The nurse practitioner is going to do it slowly and gradually. They don't just blanket discontinue these medications. So if you're on your very last part of the taper, sometimes that taper lasts a couple of weeks to make sure that they can come off of it. But we're looking for, is it helping? And then as we're doing the GDR, Are they getting worse, or are they able to cope with some of those skills easier? Now, antipsychotics is a very weird one because we could be having delusions, could be having psychosis, we could be having hallucinations. So putting someone on an antipsychotic is a big deal. So we're not looking for those delusions or the hallucinations to be resolved within 2 to 3 days. But what we are looking for is, did that Seroquel sedate them so much that it's hard for them to get up in the morning? Are they groggy? Are they slumped over in the chair? Same thing with like a Zyprexa. Are we going to have those side effects? We're looking for stuff like akathisia, which isn't a very common thing that most people know about, but it's the restlessness inside the body, and they don't know what that restlessness is. And so sometimes you pace back and forth, back and forth, back and forth. Sometimes they're in their wheelchair going up and down their hall, but they can't express to you why in their brain they keep wanting to move. And then if you've got a patient that's ambulatory and their gait isn't steady, or if they've had a recent fall, those are the things you're looking for. Also, the side effects of edema. Some antipsychotics cause edema, so we're looking for those. And then sedative hypnotics. Now, hopefully we're not giving you Restoril or Ambien, some of the higher, more acute medications. But if we're putting you on melatonin, are you sleeping better? Are we putting you on, like, let's say the trazodone? Are you sleeping better? If we're putting you on something like Lunesta, are you sleeping better? So we should be sleeping better, but we shouldn't be hungover the next day. We shouldn't be sedated the next day. So that's the sort of thing that you're looking for. A weight report, there's actually a weight report in there. You're going to go and run it every week. So if Monday is your slowest day, which probably happens never, or Friday is your slowest day, you've seen all of your patients all week, Friday is going to be your easy day, and you find out the doctor, the nurse practitioner, they're all in there, and we're trying to struggle for patients to see, maybe this is the day you run your weight report. So you're going to run this at least every week. Again, falls, wounds, weight losses. These are the highest litigations and the highest survey tags. So we're going to make sure that we're running this every week. We're going to go to reports. Remember, we used clinical for almost all of our stuff thus far. So right beside clinical is your reports. We're going to go to the weight and vital exception report. And there's actually one called that. And so this is what it looks like: weights and vitals exception. You're going to, once you get in there, unclick all of them. There's a list of vital signs. So you've got blood pressure, you've got pulse, you've got respirations. The very top one is weight. You're going to unclick them all and just select the weight. Then you're going to select the date range. So it's always from the beginning of the month. So January 1st to January 7th, January 1st to January 14th for the next week, January 1st to January 21st, January 1st to January 28th. So you're always going to do it a month. So it will give you your 5, 10, 5, 7.5, and 10% weight losses, just running them by that date range. Top right is going to be the run report. And so I wanted to clarify, because sometimes it's not clear. On an MDS, anything over 5% is documented as a 30-day. So if you can see this 5%, regardless of what the whole rest of the note says, if this says 5% here, we're saying that that's a 30-day note. So what we'll say in our HPI is patient has had a 7.4 pound or 6.2% weight loss in the past, and here's your answer, 30 days. Now 7.5% is called 90 days and 10% is 180 days. I can't tell you why they do that, but they do that. So this patient, even though they've lost 9.7%, it's over a 90-day period that we're reviewing that. So this patient would be having a 12-pound or 9.7% weight loss in the past 90 days. That's how you're reading this. And then this last one, you're thinking, gosh, they've had a 13% weight loss. I don't want you writing the patient's lost 10%. They haven't. The 10% reflects the 180 days. So this patient has had a 17.4 pound or 13.5% weight loss in the past 180 days. So you only have to document one of these. You're going to document the most recent. So if they have a 5, 7.5, or 10% weight loss, this is the only one you would have to document on. If they only have a 7.5 or 10, then you would document on the 7.5%. You would document over the last 90 days. Now, if they still have a weight loss that is triggering for significant over the last 6 months, you would absolutely document on this patient. So that's how that reads. It's a little bit difficult to understand sometimes but this is based on the MDS. So I'll bring that. Weight losses and the vital exception. So you're going to go under clinical weights and vitals. Under the HPI, you're going to document patient has had a significant weight loss. It could also be a weight gain, because if you've got CHF, if you've got lymphedema, if you've got dialysis, we're looking for weight gains as well. And so you're going to put of whatever percent, number of pounds, and then in 30 days or 60 days or 30 days, 90 days, or 180 days. And so you're going to document any reason for weight loss. So we're going to document the diet, if they have supplements, an appetite stimulant, RD evaluations. We're going to evaluate how the patient eats. Do they need encouragement? Do they need to be fed? Are they clamping their mouth shut during meals? Why the patient isn't eating well? Are they nauseated? That's an easy fix. Do they have GERD? No appetite? Are they depressed? Has the dietitian already given them a diagnosis of malnutrition? Did we get a CMP? Did we get an albumin protein and a prealbumin? So under HPI, there is a snippet for protein calorie malnutrition. So in order to use that, if you've got a low albumin or a low protein, in order to use that, you're going to have to review it. And now we always review every snippet anyway and adjust it. This one specifically. So in order to qualify for protein calorie malnutrition, you have to qualify for 2 out of the 4 problems. So there's one that's significant unintentional weight loss, which you might use on a regular note, and it doesn't have to be on a weight loss note, but this counts as one item for a qualifier for protein calorie malnutrition. Muscle mass loss. I don't need to be the one that tells you what that looks like. We all know what muscle mass loss looks like. Subcutaneous fat loss. So let's say you have a patient that's 300 pounds, they drop down to 250, now they're 220. So do they still have subcutaneous tissue and a large amount of it? The answer would probably be yes. However, have they lost subcutaneous fat? It doesn't mean they don't have any, but have they lost that? So an 86-pound patient is obviously going to be yes, maybe even a 100-pound patient. But would your 220-pound patient have subcutaneous fat loss? If they were 250, 260, 270, then the answer would be yes. And then functional decline noted in decreased strength and mobility. So usually most patients have muscle mass loss and functional decline. And then subcutaneous fat loss and weight loss kind of go hand in hand. So do you have 2 out of those 4 that meet the criteria? If you do, delete the ones that aren't applicable. So maybe there's one that's not applicable. Maybe all of them are applicable. But if you don't have unintentional weight loss and you leave that in there, now your documentation is not accurate or appropriate. So make sure you look at that. And then, do they need a diagnosis of adult failure to thrive, sarcopenia, protein calorie malnutrition, cachexia, weight loss, anorexia, contractures, muscle wasting, and atrophy? Why am I putting contractures on here? Because contractures decreased muscle mass loss, functional decline, and decreased strength. So people, random people, just don't add these diagnoses in. These are diagnoses that we have to give. So yes, maybe the dietitian would put in a protein calorie malnutrition diagnosis so that she could put in a med pass. But if you're doing a note on weight loss, you should have weight loss in there. You should have adult failure to thrive if they're 80 pounds. You should have sarcopenia if they've got muscle wasting. You should have anorexia if they're losing 5 pounds every single week for 6 weeks straight and they're not eating anything. So these are diagnoses that would be required for you to put in. So you go to the patient's chart, and then under medical diagnosis, you would add that. So I even went to the extreme of giving you the diagnosis. That's the ICD-10 code for him. Do all patients have all of these diagnoses? The answer is no, they don't. However, a lot of them have a lot of those diagnoses. So if you're looking and you're not finding them, you want to put them in. Why? Because that pulls over from your next note to your next note to your next note, and you want to be able to say this patient is having this issue. That way, when they continue to decline, and heaven forbid that you're on the stand and you let my mother lose 50 pounds and she died. Well, she had all these other risk factors. She had anorexia and wouldn't eat. We tried to give her appetite stimulants. She had contractures. She was a quadriplegic. So she had muscle mass wasting or muscle wasting and that sort of thing. So these are very important diagnoses. If they don't have them, do they need them? So wounds, I don't have a report for you. You got to get that from either your DON or the wound nurse or the wound doctor. You're going to assess wounds on admission, on every visit note, and at discharge. So if you're seeing a patient for something, you're going to be looking at that wound. Why? Because anything affects the wound. Protein calorie malnutrition, weight loss, infection, everything really affects this wound. So when you have the wound team come in, and let's say they come in on a Monday and they do wound rounds, approximately 2 to 3 days, maybe 4 days after they come in, you are going to go in and assess the wound as well. Now, Medicare says we can't have a duplication of care, meaning you cannot do the same thing that the wound team is doing, nor would you want to. You don't want to go in and stage it. You don't want to go in and do measurements, undermining, tunneling. We're not allowed to do that because it's a duplication of what the wound team has already done. What we're looking at is the dressing, the drainage, the peri-wound. Is the wound improving or not improving? And do we need to change treatments? We don't know, and we can look in the progress notes from the wound team, and I would always advocate for you to do this. If the wound is stable, not healing, healing. So I would always do that. But we're wanting to see if they debrided it, if the wound has gotten worse, if there's more drainage, if the drainage is clear. If the drainage is green, we may need a wound culture. So sometimes wound doctors will say, please don't get a wound culture. That's because the assumption is we're going to go in and get the green stuff. No, we're going to clean the wound very good, very aggressively, and then we're going to get the wound culture. So if you don't know how to do a wound culture, please watch the doctor do it next time so that you understand how to get a wound culture. If this is a new wound, you're going to assess it. You're not going to stage it. You could say wound of unspecified or a pressure ulcer, unspecified, you can describe it. You can say there's an open wound. It is on the left buttocks. It is draining whatever, serosanguinous, sanguinous, drainage, whatever. And then you're going to put a treatment in place, and you're going to put a referral in for the wound team. You may even want to text via secured communication that to the physician. Okay, we want to make sure that we're communicating. We're not leaving this wound without a treatment for maybe 6 days because they just came in yesterday. We want to make sure that we've put that in place. On the other hand, we don't want to say it's a stage 2 pressure ulcer. The wound team comes in 1 day later, and now it's a stage 4, because now we've let this wound deteriorate from a stage 2 to a stage 4, when in reality, it might have already been a stage 4. Or you classify it as a stage 4, and they classify it as unstageable because they cannot see what's underneath the eschar. So we don't want to do any of that. We don't want duplication of care. Super important on this, visits by payer. So there's 2 types of payers, and it used to be simple. I would tell you that this is the facility payer and this is the provider payer. So you're going to want to look at the Medicare beneficiary number. That's how you know if they have Medicare or not. Medicare A, Medicare B, that's their Medicare number. This is what they're getting paid for from the facility. That does not affect us. However, as of July 7th, 2025, CMS is asking when you do your CPT code, there's 2 CPT codes for each code. There's one that says SNF 99310, and there's one that says LTC 99310. Same thing with the 99309. It's an SNF 99309 and an SNF or an LTC 99309. You are going to get that information. Any person that has Medicare, Medicare Advantage, Medicare HMO, if it says Medicare, this is a Medicare level, then that place of service is going to be SNF. Anything and everything else is going to be LTC. So it's very important. Before they wanted you to do it, they wanted it to be right. Now they're penalizing and taking money back. So if you put the wrong place of service, it's not like you can say, oops, let me fix it and send it back out. They will reject that claim. So anything that says Medicare, Medicare level, Medicare A, Medicare Advantage, that is an SNF. All of the rest are going to be LTC. So how often can you see the patients? I think this was in the payer video, but again, I need to bring it back to your attention because this is such an important issue. So a Medicare A patient can be seen 3 times a week, split between providers, and with any new change of conditions, we should be seeing them weekly, at least once a week. So let's say the doctor comes in 3 times a week, we still need to see them once. We still need to see them at their baseline and how they're progressing. Doctor goes out of town, doctor's sick, you don't know, and you don't know how the patient is really. We don't have a baseline. So it's very important that we see those Medicare A patients at least once a week. So if there's no provider in the building, and we actually have several that the doctor will come in for the first visit and then not come in for 4 months. And the rationale behind that is they have to see the patient every 2 months, but it could be replaced with a nurse practitioner. So every 2 months, it would be a doctor, but then they could be replaced in the next 2 months by a nurse practitioner and then the doctor. So you might not have a provider in the facility. So you should be seeing that patient enough that they are A, medically necessary, and B, that you're keeping them out of the hospital. So when I talk about any of these, are these visits medically necessary? We never do a visit just to do it. We never do a visit just so we can get our numbers. Every visit needs to be medically necessary. So a long-term care patient, but they've got Medicare. So these could be the Medicaid long-term care. They could be a Medicaid pending. It doesn't matter what their status is. If they've got a Medicare beneficiary ID, you can see them every month. And then for any other issues. So for wounds, for weight loss, for falls, for changes of condition, for new skin issues, anything you could see them for that is medically necessary. The HMO and the PPO is as needed for changes. Hospice, you can see once a month, and for emergencies. So let's say you've got a patient in pain and they're going to send in an RN. An RN is not a nurse practitioner. So if we are assessing them for pain and the nurse practitioner cannot come in, then we could see that patient and it gets billed to hospice. So we can see them once a month, and then for emergencies. Medicaid patients once and for an emergency only. I got to clarify emergencies. It's not a positive UA and they need antibiotics. It's not a cough. It's not nausea and vomiting. It's to prevent them from going to the hospital. So emergencies only. If the patient goes to the hospital and comes back, that's not a reason to see a Medicaid patient. If a patient goes to the hospital and they end up on IV antibiotics, they've got a wound debridement, they're a sick patient, then they come back, then yes, you can see the patient. But only every 30 days or 28 days, actually, can you see a Medicaid patient. So if I see that you're seeing Medicaid patients, and you're not getting paid for them, I'll figure out when the last time that you did get paid for them, and I will let you know. You can see this patient on the 15th of every month or on the 20th of every month, because we can actually see when the payment is coming through. It takes like a month or two, but we can see that. When you click into a Medicaid only patient, in TrueRCM, there should be a red box on the top that says this is a Medicaid patient and they've already been seen this month. That being said, don't wait till you do your visit. Every visit that you do, you should know their pay source before you do them, because again, patients change pay sources and you should be looking at that on a daily basis. And then any hospital insurance, the medical director gets a medical stipend to see those patients. The facility gives them money every single month to see the patients, to attend QA, that sort of thing. So if they're a hospital insurance, then you would not see them either. Until further notice, VAs we don't see, even if they have a Medicare. We are trying to get clarification. We do have a billing department that has gotten multiple rejections, actually all rejections from the VA, trying to go through and bill Medicare. At this point, we have not been successful at that. So if it's a VA patient, you need to get prior auth, meaning you need to call the VA, you need to sit on hold, you need to determine if you can see that patient. And then most likely they're going to say, no, send the patient here to the VA and I will follow them. So just know that on your VA patients, you should not be seeing them. Checking Medicare numbers, we showed this on the payer source, but this is a way you can run the report to see who has the Medicare beneficiary. So you're going to again come to reports, and then you're going to go to the resident list report. Easy to remember because it's the list of residents. Make sure you click current patients under the status. You don't want the status to be all, because then it will pull all of the discharge patients as well. So make sure you pick current. Include outpatients? No, we don't want any outpatients. And then you're going to click down here at the bottom and it has a Medicare beneficiary ID. There's a lot that look the same: Medicare number, Medicare HIC, Medicare whatever. You're wanting the Medicare beneficiary ID. So you click that. So literally all you're clicking is the status of current and the Medicare beneficiary, and you're going to run that report. And this report looks like this. It will give you the patient's name, and then it will give you all of the Medicare numbers. The ones that don't have numbers in this, and I hope you can see that, These guys don't have Medicare numbers, so you would have to verify what their pay source is. If they're Medicaid, you can see them once a month. If they're Medicaid pending, you wouldn't be able to see them. If they're VA, you wouldn't be able to see them. If they are hospital insurance, you wouldn't be able to see them. So remember, you're looking for the Medicare number. That's the important thing to look for. Long video, I apologize. I apologize for a couple of glitches in that. But go ahead and email me any questions that you have. If you need a copy of this PowerPoint, it is located under the resource section tab of TrueRCM. But let me know if you have any questions, opinions, stories to tell, issues that you're running into. Let me know. Otherwise, thank you so very much for watching this. I know videos are very long and lengthy, but there's so much information that you need for us to do great notes. So again, thank you, and I hope to see you soon.